Imagine running a thriving bedside urology consult practice for 7 years at long-term care facilities as a solo practitioner, and you are covering 90 facilities. Our interview today with Melissa Blackburn, a nurse practitioner, will surely intrigue and possibly inspire you to take on this role in your area. We will discuss her practice, challenges, successes, and tips for anyone interested in this niche area of urology. As always, if you have any questions during this live stream, please leave them in the comment section. I will definitely pass your questions to Melissa. And if you're watching this on the replay, I welcome your comments and suggestions as well. Some of you recently joined the Thriving Urology Practice Facebook group where we are live streaming now, may not know me. My name is John Lin, your humble host of this small group of thousands of US-based urology practice folks. This is where we crowdsource practice management solutions for everyone's benefit. And speaking of benefits, let's have Melissa share her urology-specific long-term care experience with us. I want to thank you, Melissa, for kindly sharing your time on this beautiful Saturday morning with us. Welcome to the program.
Hi, John. Thank you. Yes, my name is Melissa Blackburn. I am a board certified nurse practitioner practicing in Massachusetts and Connecticut, specifically with geriatric urology for the last 7 years. And I am thrilled to be here. So honored that you asked me to be interviewed and speak. And part of what I do is educate. And this going into this year, I have decided that it's time to spread the wings, make a more national presence, including podcasting, more of a social media presence, and speaking at various engagements, conferences, etc.
Well, it sounds like you have a lot of information to share. And the interview, how we ended up here today, was born out of a post response that you made. And it was extremely detailed and comprehensive. So I'm going to just quickly talk about some of the things that you mentioned.
Mhm.
You take care of patients. The average age of your patients is about 80 to 85 years old. And you take care
Correct.
of at this time, long-term care patients when they're in the long-term care facilities only, and you treat men and women. Is that correct?
Correct.
Okay.
Yes.
I know you had someone who mentored you initially, and I'm really looking forward to you sharing some of the insights that you have so that this will serve hopefully as a mentor video or maybe a jumping off point for someone who may be interested in this niche practice. So share with us how you started getting into long-term care 7 years ago.
Sure, absolutely. So 7 years ago, I started. Actually, I took over the geriatric urology practice. My mentor, Martha Clay, who is also a nurse practitioner who practices also in Massachusetts and Connecticut, had actually started the practice. So she is the originator back 30 years ago now at this point, anyways. And she was actually working in uh, a GYN office, and she decided that she wanted to go out on her own, and she treated only women at that time. And she started to go into the long-term care facilities that were local to her. And originally she thought, oh, well, I just need one building and, that should be good. And once she got in, you start to learn. She started to learn that, well, I'm definitely going to need more than one building. And it grew. So when I met Martha Clay back in 2014, 2015, I was actually working in long-term care, but as geriatric uh, primary care in the long-term cares. And I had met her, and I was immediately interested in what she was doing. She was focusing on an area that, for myself at the time, when we were doing exams on patients, GU, the rectal exam, were all deferred, 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 deferred. No one
Mm-hmm.
ever looked at that area. No one ever looks at that area. And that is one of the systems that has the most complaints from this population. Yeah, I told you yesterday there's 5 things that that people worry about in their day in long-term care because their world is so small. So they worry about what's to eat. They want to make sure, the food is good. They want to make sure they can sleep. They need to have their sleep. They want to make sure they're not in pain. They want to know about activities, especially bingo. You never mess with bingo in long-term care. So that I actually have to revolve my visits around making sure it's not bingo
Oh my gosh, love it.
time. And then urology. So it hurts to pee. It itches down there. Um, I have a prolapse, which they don't know that that's what it's called, but something's hanging out. So those are the kinds that things that they worry about, bowel and bladder.
So before we
So it
jump into
Mhm.
any more details, not every state allows nurse practitioners full practice authority. And you
Correct,
cover Connecticut and Massachusetts, correct?
correct,
And in those states, nurse practitioners have full authority, meaning you can prescribe, you can diagnose, you can treat.
correct.
So that's an
Yeah,
advantage. So not
correct.
people may be watching this program from many different states. I just want to make sure that they look into that first before they jump, wholeheartedly into this, making sure you have the prescribing authority, the full authority, or you
Right,
can work
correct.
under a supervising physician.
Well, I was gonna say that's the other option. So if you have a great collaborator, you could always practice with a collaborating physician. However, though, in Massachusetts, it's interesting because for years and years, the nurse practitioner political group was pushing for independent practice. We had full prescriptive authority for
Mm,
years, but they were pushing for independent practice. There's a lot of rural areas in Massachusetts. It's not just everybody thinks of Massachusetts, they think of just Boston, but there's a lot of
yes.
like Berkshire rural towns, etc. So the physicians aren't maybe as accessible in those remote areas where nurse practitioners actually live. So for years they tried to push for independent practice. And it was interesting because it was COVID that finally
Mm,
changed the mind of the state. And
mm-hmm.
actually, on January 1st last year of 2023 was when nurse practitioners were granted independent practicability in the state of Massachusetts.
Oh wow.
Now, Connecticut, on the other hand, though, had already gone to independent practice a couple years prior. They did have a stipulation on it, though, that you had to practice for the first couple years, irregardless if you were a seasoned nurse practitioner or if it was your first day out of school, that you had to practice with in collaboration with a physician in your specialty. So actually, I was independent practice in Connecticut before I was Massachusetts. But when I was new to Connecticut, I actually had to connect with a urologist out there. It was a female board certified urologist who was fantastic out of New Britain, Connecticut. And I worked with her for a couple years before I was able to not need or require a collaborator. And then Massachusetts came along last year.
Boy, but that is sure is nice to have that
Mhm,
mentorship to get you started.
mhm,
So I'm hoping that
mhm.
people who have watched this or will be watching this or watching this will possibly take after you and cover some of these long-term care facility patients. As you mentioned in the post that you made, it's a really forgotten population.
Mhm. Mm. Yeah. So for a long time, I always thought to myself, well, what is it that exactly that I do? Well, yes, I'm a nurse practitioner. I take care of people. You want to help people. That's always the classic answers. But after years of looking into it and thinking about what it really was that I did, I take care of vulnerable populations.
Mm.
And along with pediatrics, geriatrics is probably even more so a very vulnerable population. And then you can dive into that, and patients in long term care are even more susceptible to being uh, at a vulnerable state. And then bring it down to urology, where they're completely ignored. And I think that's probably what attracted me to Martha and her practice and mentoring with her. So when she retired in 2017, I had taken over. And actually, at that time, when I took over from her, she had about 50 buildings between the two states.
Oh
And
wow.
during Now, and this was pre-COVID. So, 2017, I had about 50 buildings I took over, and I grew it to about 90 within those 2 years. However, COVID hit. And when COVID hit, all of a sudden, one day I had this thriving practice. And then the next day, you can't come in anymore. No one could go in. Even the primaries that were in the building seeing the patients were doing telehealth conferencing. So you'd had a nurse who was in the long-term care walking around to see patients with like a FaceTime or video computer so that they
Wow.
could see the patients that way. So it was a while, probably not till about fall time, where I could start making the calls, "Hey, can I come in? How are things going?" And I could start to come in, but it was still sporadic for a very long time, but I just kept at it. But then there was a point in 21 where I kind of got really frustrated. It was, we were still under the COVID scare, and especially in long term care anyway. And I would call a building, say, "I'm coming in. I have these 15, 20 patients I want to see." "Oh, you can't come today. We have COVID in the building."
Oh, gee.
So it's very hard to run a practice like that when you think you're going to have 20 patients or a schedule for the day, and all of a sudden there's no patients to see. So that kind of became the theme, like, you can come in, but then if there was COVID, they would cancel. And that was happening often enough where I kind of stepped back and took a break, and I felt like I need to let COVID pass a little bit more. And then in 20, let's see, 2022, I actually called Martha back up. I said, "Hey, all right, it looks like COVID, we're in the clear for the most part. All the specialties were coming back in because you have wound, cardiology, all the ancillary services that were coming in to see patients again." I said, "All right, I need your help. We need to get back into these buildings." And I was starting to go to all the buildings that were still working with me, letting me come in. I would gowning up from head to toe. I mean, we all know that scenario. And she was working on the phone for me, marketing, saying, "Hey, we're here." The other issue was is that all the leadership had changed in the building. So many things had changed. The
Oh,
leadership had
gee.
changed in the building. Yeah. So she was reaching out to people, trying to find out where people had gone, trying to connect with them.
So
So
they
it
had
was a
disappeared.
real task. It took us and I thought, "Oh, I've got Martha on it. We'll make a call to these buildings. We'll get going again." And it took longer than I thought. So it took a good year till maybe like, because we had started in about July of 2022, and it probably wasn't until fall of last year, 23, where I felt like, oh, we're getting going again. So, and at this point now, we're back to normal, where I'm back to 90 buildings. I have all these buildings in a rotational cycle, and it feels like it was pre-COVID.
Oh, it sounds like you are finally back on normal footing after the pandemic hit. And now, in the last year
Correct.
and a half, you're back to 90 buildings. So, speaking of buildings, how did you? I guess you inherited 50 buildings. How did you or your office manager recruit new buildings, if you will? Speak to me as if I don't know anything about this industry, because that's pretty much most of our audience.
Mhm. So networking and developing good business relationships. That's how you get more business, find more business, reaching out to people. I would do some talks to some of the populations in the buildings uh, about my services and what I had to offer from a point of view, how it would help the building, it would save them money in the long run, etc. If there was a director of nursing in one building left, or any of the other leadership, administrator, etc., if they left and went to another building, I would always make sure to find out where they were going, because that's another way to get another new building. Mm.
So when
So
people,
that's probably,
yeah, it sounds like what you're
yeah,
saying
go ahead.
is leverage all the connections you have, even though
Correct.
someone has left
Yeah.
a practice or a long-term care facility. Where do they go? And then follow that
Mhm.
person, maybe contact them via LinkedIn and say, hey, you know what? I'm still here. You're still in the geographical area. Maybe I
Mhm.
can continue to help your residents there.
Right, correct. And even connecting with the nurses, if they went to another building, they would talk to their administration in the new building and say, "Hey, we have a urology provider that would come into the other building. She was doing great things. Can you talk to her and possibly can we get her in our building here?" So the other thing that I'm working on now is stemming probably a little bit beyond that. So I'm reaching out to contacts that are we're looking for contacts that are higher up the corporate chains. So anybody that I know, because a lot of administration maybe has left and gone to corporate. So we're reaching out to corporates, the healthcares for long-term care that are out in this area and reaching out to them and going kind of higher up that networking chain and get because they can get us into more buildings. So say if you have, a corporation, I go to this building, they're owned by ABC Corporation, but that director of nursing now works for corporate. Well, now this director of nursing is circulating through multiple buildings.
Mm-hmm.
So that is what we're doing now. And instead of getting into one new building, we might get into 4 or 5 new buildings.
Mm-hmm.
So, you need to talk to the right people. You need to find the key people. Also, to even at the state level, in Connecticut, DPH has a list of consultants. They have no urology consultants for long term care on that list. So when they go in to do a survey and they find deficiencies, they'll say, "Hey, here's a list of consultants." They can't recommend anybody, but if you're the only urology consultant on the list, hopefully you get a call, right? So, and then reaching out to now also to different nurse practitioner organizations. So, GAPNA and wanting to speak, NADANA, which is the North American Director of Nursing Association. We did a webinar for 500 people last fall, for 500 director of nurses last fall. And from that, we've made more connections with a pharmaceutical that wants to print some papers for us, to speaking at other conferences in other states. So not only, have the national conference in once a year, but all the states have their individual uh, groups. So speaking at those also. So it's just about talking and sharing your information and education. And actually, from that Facebook post that I had commented on, a
Yes.
couple of your followers have reached out, and I've had one conversation, anyways, with a urologist who's down in Florida, and she is actually already in assisted living, but for a larger urology group. She's part of a urology group or a hospital
Mm-hmm.
setting. I'm not sure exactly
Mm-hmm.
which, but anyways, she's looking to possibly go out on her own. So we had almost an hour conversation about the process of setting up a business and how she could do this. And she can even offer more services than I could because she was explaining to me how she has a disposable
Cystoscope.
cystoscope
Yeah.
system. Yes. So I don't do any cystoscopy. So if I do that, that's where I need my urologist and I
Yeah.
send them
I
in.
hear you.
So,
Before
but
we jump
yeah,
into the nitty gritty of the actual procedures, let's answer a quick comment or perspective. I
sure.
believe this is a physician, and
Mhm.
he said that I fear my APPs would consider going independent and abandon me as I need them, wanting to
Mhm.
add this as an ancillary opportunity for them and my practice. How would you respond to that?
Mm. So I wouldn't. Why would you be afraid that they're going to leave you? Is there a reason they should leave you? I guess is my first question. But I'm all for the art of negotiation. So I would probably talk with them first of all. Why do you want to leave, or even your fears on why they might leave. If they're a valuable asset to your practice, let them know that. People want to know that they're doing a good job. Uh, it's a huge motivator. And maybe it's something where, okay, you want to be more independent, but maybe you don't want to take on a whole independent private practice yourself and going in long term care. Let's talk about maybe starting a division out of the urology practice that I already have. Maybe we can get you going in your own independent side practice that's part of the practice as a whole. So there's a lot of room for conversation and negotiation there for sure, absolutely. Because a lot of people, they think about too going independent or being on their own. It is a lot of work.
It's a lot
I-
of work.
it's a lot of work, and some people right off the bat, no. I have a son that's like, nope, I never want to work for myself, and I have a couple others that are. I have four boys, but
So a lot of times people,
they're
yeah, people ask me for career advice and things like that.
yeah,
The number one thing that they need to know is you have to know yourself. Self-awareness. Are you the kind of person
yeah,
who likes to run your own practice? Are you the kind of person who is okay getting directions from
right,
somebody else, being an employee, for instance? You
right,
have to know yourself first before you venture on to
correct,
do whatever it is that you want to do. Now, to answer
right,
this
exactly.
urologist question, the important thing is, I think it's human nature. We generally have that negativity bias. We always
Mhm.
think, a lot of us have that scarcity mindset. There are not enough patients. They're going to steal patients from me. I have acquired now an abundance mindset. There's so much to go around that I'm
Mhm.
happy to help other people get to where they want to
Right,
go. So that
right,
scarcity mindset is what limits us. And in this situation, possibly limiting this physician in not possibly training the APP so that he or she can go out and serve a larger good, an audience, a group of patients that is grossly underserved. And as you mentioned in the
right.
post response, unfortunately, these patients are not welcomed to a lot of urology practices because the complexity of the situation, the lack of communication, the poor history, and not having an informant regarding the patient's situation, transportation issues. These are some of the concerns where a lot of these patients are why a lot of these patients are not seen in urology practice. But you don't want to abandon them. We want them to get good care, and that's where you come into play.
Right, correct. And they absolutely are abandoned. They're just given antibiotics. And that's a whole other conversation, but it's just repeat antibiotics. They're sent out to the ER, they get an antibiotic for a UTI. It's billable. It's just it's not good care, as you said, and we want them to get good care because there's definitely that strong mind body connection, and if they're not feeling good down there, then it's not they're not going to have a good day.
Yeah, just like
Like I
anything
said, it's
else.
one
So
of the
much.
five things in their day.
Yeah, yeah,
Yeah.
bingo.
Yes, yeah. I forget. Yeah, okay, six things.
The thing is, they can't enjoy bingo if they are feeling bladder infections or burning in the pelvic area or feeling prolapse or incontinence. They're thinking, oh, can somebody smell me? Where I'm out there practice or playing bingo. So a lot of these things that we're talking about in
Mm,
urology impacts on the entire patient, the biopsychosocial
correct.
aspects of
Right.
for the care of that patient. Okay, now we know how you acquire some of these long-term care facilities and talk about the logistics. I know you cover 90 different facilities, 90 different buildings. You see about 20 to 25 patients a day. How does that work to a layman like me who is not doing this?
Right. So the all the buildings are in a rotational cycle basically, and it's volume driven. So if I have a building, maybe it's relatively smaller, it's only got 10, 12 patients in it that I see, they'll be in a 3-month rotational cycle. So I will see them every 3 months, once a quarter. If they have a new patient that they want me to see, I'll pop in at some point when I'm in the area and see that patient. I don't make patients wait 3 months until I'm back again. And
Hmm.
I'm always reachable by phone, which I don't get too many phone calls, but they can always reach me if they have a question on a urine or something like that. But it's volume driven. So if I have a large building, of a large building that's down in New Haven, Connecticut, and I go there every month. Sometimes I go there twice a month. So they have a lot of patients, a lot of issues going on. So I am there often. Uh, and then the last type is if they've got maybe about 15 patients or so, I'll go there 2 months. Well, maybe if they got 20 patients, 15 to 20 patients, I'll go there 2 months on, 1 month off. So I'll see half of the group 1 month, the other half the next month, and then I'll have a month in between. So 2 months on, 1 month off. But the big thing is having a presence in the building. So when you go into a building to see your list of 10, 12, 15, 20 patients, whatever you have for that building for that day, they may say, "Oh, can you see Mrs. Smith?" Or can you also see? So you're getting more business just by having a presence in the building. Had you not been there that day, or had you not going to be there for 3 months, well, they may not think about that. And I've seen that sometimes where the patients, well, we sent them out to the urologist. I said, well, okay, so I'll see that. I said, okay, I'll see them. So I'll see them and I'll, I'll write in my orders, do not send out to the urologist, unless it's something interventional or that they need.
It's a big expense
Or,
for the long-term
it,
care facilities to send that
mhm,
resident somewhere else.
mhm,
So if they can take care
yes.
of that patient through you in that facility, it really is good for the patient and good for the long-term care facility.
Right, correct. So, and especially those Med A patients. So Medicare A pays a
Medicare Part
global
A.
or but
Uh-huh.
Part A. So I do not typically see those patients. On occasion I do if the facility is going to write me a check directly to see them. I cannot bill insurances for Med A because they are part of the global benefit that's being paid to the facility. So those are the patients that end up going out to see the urologist. Say if they, had an ORIF, fractured their hip, they're in long-term care for rehab. Now they have a Foley, they need a voiding trial. I can't see them. I could do a side consult, but it's not going to be the same. So they'll end up going out. Then unfortunately what'll happen is, and it's not the fault of the urologist, it's all the things you had mentioned before. They're poor historians, they may have dementia, they can't get up on an exam table. So you'll see them and maybe write orders for Flomax or increased Flomax and then pull the catheter and have them do a PVR, check a PVR 8 hours later, 4 hours later. And then a lot of times they end up with the catheter back in.
So
So,
speaking of
but
PVRs, tell us about how
mhm,
you, I know you mentioned in your post, you do
mhm,
bedside PVRs and you have a portable ultrasound. And also
mhm.
a lot of people ask about that bedside cystometry. So if you can comment on the ultrasound and the cystometry, that'll be great.
Okay. So ultrasound, I use the butterfly. And that was actually thanks to your group because I was using a Verathon. It was an old one and I loved it. I just didn't want to get rid of it. It was just so easy. But it tanked on me. So I had to get another one, reached out to your Facebook group, and someone had suggested the butterfly. So I looked into it and I was like, this is fantastic. So I love it. Actually, the patients love it because they're older population and they see you connecting it to I connect it to my cell phone and like, oh, wow, they can connect anything to your phone now. So it makes for a little bit of conversation.
Sure.
And I think it's fantastic. I use it, it's very portable. I got the case with it and I just connect it to my phone and just put it in my pockets and I carry it around to all the patient bedsides. The cystometrogram,
So now instead of
uh,
guessing after that ORIF patient
yeah, yeah.
has the catheter pulled, you can now assess the post-void residual with that ultrasound at the bedside without having the patient go somewhere else or having a nursing staff catheterizing the patient to determine the post-void residual.
Correct. And many of these buildings don't have a bladder scanner. And if they do, half the time it's broken.
Yeah.
So there's a small number of facilities that actually do have a bladder scanner. So yes, they end up cathing the patient, which I try to avoid at all costs
Yeah.
because depending on the patient, if they have behavioral issues, etc., they're not going to tolerate being straight cath every so many hours for a couple days to check their PVRs.
Yeah, that is very uncomfortable for sure. Kind of like
Mm, right.
even in a clinic,
Eh,
when I do the post-void
yeah.
residual ultrasound, I tell the patients, yeah, we used to have to stick a tube into the bladder through the urethra to do this in the past, but now we don't have to do that. They're always extremely grateful. Okay,
Yeah.
so this bedside cystometry is actually how we used to do things, but please explain how that is done, where you can determine overactive bladder, post-void residual, etc.
Yeah. So what I do is part of my exam. So I will ultrasound their bladder first. And honestly, the majority of patients, you can't get to the toilet and have them void on command. Many of them are in some sort of incontinence product. So I'll open the product, the brief, the pull up, whatever it is that they have on. If it's wet, fantastic. So I know that they've probably recently wet. If it's bone dry, I have to take that into consideration. I might ask them, when was the last time you went to the bathroom? And they may be able to tell me. Sometimes they tell me yesterday, so that's not very useful. But anyways, I'll scan their bladder just to get to see what their volume is. So say if their bladder, I'm getting a reading of 400 cc's. Then I go and straight cat them as the initial part of my cystometrogram. And I only empty out maybe 100 cc's. Something's got to account for that 300 cc's. And many times I've actually picked up many masses that way. So that's what I was actually picking up. So that's one reason why I do it that way. Then, as part of the cystometrogram, so I'll straight cath them, empty the bladder, lets me look and see how their urine is, because they're not going to be able to go on the toilet. They're not going to be able to give me a sample. Most of the time, when I ask the nurses to get a sample, they're like, good luck. It's always got to be a straight cath, which is better, anyways. But so I'll straight cath them. I'll be able to look at their urine, see how it looks, smells, anything floating in it, etc., the amount. Then what I do is I take a 60 cc irrigation or piston syringe, connect it to the end of the straight cath, and then I use about 300 cc's of sterile saline, sterile water, whatever they have on hand in these buildings. And I start to pour it in. And I'll tell the patients, I said, your job is to tell me when you feel like you got to go pee. Okay. So they'll sit there and we'll be chit chatting, and I'll start pouring the fluid in. And if I pour in, the syringe will hold about 60 cc's, obviously. So if I start to pour it in and all of a sudden at 30 cc's, 60 cc's, maybe 100, they're starting to have some urgent continence, saying, oh, I got to go. Then I'm getting closer to maybe 200, and like I can't hold it anymore. All of a sudden I see an air bubble and it starts backing up at me. That's overactive urgent continence. So I know right there. And then I also compare it to, well, if they only had maybe 30 cc's or only drained out 30 cc's out of their bladder, clearly they have an overactive urgent continence issue. Then you have the patients where maybe I've already scanned them for 600, emptied 600. I already know the patient's going to be a retainer. I already know. But I want to see if they have any awareness that they have to go. So I'll start pouring the fluid, pouring the fluid. I'll get to, 200, 250. You have to go to the bathroom? Oh, I'm good. So I'll keep pouring. I'll get to 300. I'm like, do you feel like you have to go pee now? No, no, I'm okay. I'm like, okay. So I'll pour a little more. I might go to 5 of the 600, and just to give them a good irrigation, because I can bill for that too. And then I always leave their bladder empty. So I'll drain it out. I'm like, well, yep, they're a retainer. If they're not on Flomax, we'll get them on some Flomax. I'll also, if they haven't had any imaging, at least get a renal bladder ultrasound to make sure there's no hydro or anything going on or developing. So I will do that and treat them with some Flomax. Then, of course, I have the patients where I pour in about 300 cc's, and they're like, yes, I could go to the bathroom right now. I think I probably should go. Can I get up and go now? And those are the ones where the bladder's functioning pretty good, pretty normal. So those patients don't need any bladder medications. They just need some sort of program in place. So they need to be a toileting program. Maybe they just need to be prompted to go, or maybe they're check and change. So maybe they're not able to get to the toilet or even on a bedpan for some reason, and they're incontinent in a brief. They need to be on a check and change every 3 hours, 2, 3 hours.
Well, Melissa, this sounds to me like old school bedside
Hmm.
patient care, where you're
Yes,
you're you're conversing, interacting with the patient, and then you're doing procedures, you're getting feedback in real time, and then based on that information, you are diagnosing and then prescribing a treatment course for that particular patient, which I think is great.
correct. Yeah, yeah, correct. Yeah, and it's so needed. This area for these patients, it's so neglected. I'll go in to see a patient, and I always say, "Hi, Miss Smith. How you doing?" They ask me to see you about your bladder. How's your bladder doing? Oh my goodness, I have to go to the bathroom all the time. I'm in there every hour. I'm like, okay, well, I'm probably got an idea what's going on. Although you got to be careful. I always tell people maybe that I'm educating, or if I have somebody that I'm mentoring, don't be fooled by those overflow incontinence patients. They act like overactive bladder patients because that reservoir is constantly full and they're just overflowing all the time, as you know. So it's frequency, but it's not frequency from overactive bladder. It's frequency because they're retainers and they're constantly
Or it could
full.
be a tumor in the bladder.
Yeah, and I might be able to pick that up
Yeah,
on
on the
my little
ultrasound.
butterfly, and I might yeah, I would do an ultrasound,
Speaking of
right.
ultrasounds, you said renal ultrasound and stuff like that. Are you doing that also at the bedside and then
So
writing a
yeah,
report,
so
or how
in
does that work?
yeah, so in the long-term care facilities, they actually have companies that come in. So out here, it might be like Mobile X or Trident Care, and they do come into the facilities. They'll do the scan there, and then I get it same day or the next day.
And just like
So
X-rays, right? You can get portable X-ray
and
units
X-rays.
at the
Yep. Yeah.
bedside.
So
A lot of people don't
KUBs. Yeah.
realize that.
Yeah. KUBs, ultrasounds all the time. And I rarely, never order a transvaginal ultrasound. This population can't tolerate it. Even even if their vaginal vault could
Accommodate it.
accept, correct,
Yeah.
exactly. So if it is a patient that absolutely does need that type of uh diagnostic they'll unfortunately have to go out to the radiology department, but mhm.
What a lot of people don't realize is that they think, oh, Melissa, nurse practitioner concentrating on urology, is going to these long-term care facilities, take care of these patients, is something novel. When in fact, dentistry, cardiology, primary care,
Mhm. Mhm.
all these other specialties, if you will, they
Right.
already have that type of outpatient existing relationship with long-term care facilities. We're not doing anything novel.
Correct. It's just not being done. Yeah,
Yes.
they even have their own exam rooms. The podiatrist comes in. Oh, they love
Oh
the
yeah,
podiatrist.
podiatry. Yeah.
Yes, but all of them, dental, they all even have their own exam room. So it's been going on for a long time, long time. There's companies that actually they don't even have to be independent consultants like I do. They have companies like Health Drive per se. They have a conglomerate of specialties and they'll come in on a certain schedule every month.
Well, I can see somebody, maybe you, starting getting a whole bunch of APPs together and then starting something like this, so you can cover multiple states. So that's a PE, private equity venture idea.
Working on it.
Very good.
Just
Now,
trying to make a presence right now.
I hear you. Now you mentioned recurrent UTIs, antibiotic stewardship is one of the things that came to mind.
Right.
You
Right.
also mentioned in the post that you send out cultures and let's say PCR, right, for these
Mhm.
more difficult to treat infections, if you will. When I assume you collected the urine sample and then the results, say the results come back. How do you get the results? Do you have an EHR or how does that work?
So they come to me. They don't go to the facility. So when I collect a urine and send it to my microbiology lab, my NGS lab, I use Microgen uh, right now. And so I send it out to them, FedExed overnight, and I'll get the PCR in 24 hours or so. And it comes to me in an email. So they send it to me in an email. You could have a fax to your office too if you wanted to, but that was using up too much paper and ink.
Got it.
so,
Unless you capture the
so,
facts
it-
electronically.
so, huh?
Unless you capture the facts electronically. Meaning it doesn't print.
Yeah,
It's just in a document.
true, true. But I was doing paper. And so anyways, it comes, I get a email notification and then there's a provider portal. So I can go in and I can see everybody's
So you
lab
have
work
to
that
set
was
up
sent.
some sort of an infrastructure as somebody's thinking about starting this type of a practice. You have to
Mhm.
figure out how you are going to get all that information, ingest all that information, and then getting the treatment plans out to the facilities. Now, as you know, in the Thriving Urology Practice Facebook group, we talk about documentation being the bane of our existence. How do you say you get that NGS result back and then you prescribe a treatment plan? How do you document that this is what you're doing, so that whoever comes behind you will be able to look at a chart or something that something was done because of something else. How does that happen?
Right. So as far as on the facilities end, I always want to make sure that they have a copy. So I will send them a copy, either whichever their mode of that they like to receive it. So whether it's to a secure email or a secure fax or however it is that they want, I will send them the actual lab report. I have to explain it to them because they're
Got
a
it.
little bit different
Got
than
it.
Quest or maybe some of the hospital laboratories that they're used to. So you have to explain it to them. And then I'll tell them what I'm going to order. So the nurses will enter the orders into their EMR, and then they'll have that hard copy of the actual lab result. And then typically they'll scan it into their EMR. Most of them are all EMR now. There's a couple small ones that maybe still have paper chart, or actually both. So they'll have an actual copy of it.
So this could turn into a logistical nightmare very, very rapidly as you're scaling this. 90 facilities, you're dealing with 90 different, potentially 90 different ways to interface or interact with all these facilities, because they may want different ways to receive results and receive orders and
Mhm,
things like that. So that could
mhm.
probably suck up a lot of your time.
Well, I have an office manager who is part time, who comes in twice a week and helps with a lot of the administrative paperwork, scheduling, faxing, phone calls. So she does a lot of that. Each building, unfortunately, there's a relationship there. So it is my practice, but I am going into their building.
Mm,
So they're they have a choice, but I can't tell them per se always how I want things done. There has to be a negotiation and a relationship. So typically, I'll have a point person in every building so that I'm not talking to multiple people. So I have one person, usually it's the infection control nurse, or maybe it is the director of nursing or the assistant director of nursing. It's usually one of those three people. And I will connect with them and set up, well, how do you want to receive information? So, and typically it's either fax or by email. So it's only really one of two ways.
got
So,
it.
and that works really well. And the other thing too is I'm only going to one or two buildings a day. So it's, when you think 90 buildings, oh my goodness, how do you control this? Like I said, they're all in a rotational cycle. There's a lot of education, so they know how things work, and it's not overwhelming in that sense because there is a process on how things it works like a well-oiled machine.
Yeah, boy, that sounds really, really
Mhm.
intriguing. Somebody else
Mhm.
also asked, how about doing PTNS? Is that offered at all?
So you could do that. I don't. I believe that you have to do that on a weekly basis for
Right.
about 10 weeks,
So
correct?
he was asking, can you negotiate a monthly stipend for your guaranteed presence, especially for agreeing to see some of the Part A, Medicare Part A, or
Mhm.
underinsured patients? I mean, so I guess
You,
that requires negotiating with the facility for that type of
you
service.
could.
Yeah,
Yeah, you could have a contract and with them and see their Med A patients. Absolutely. Right now, it's just kind of like on an a la carte per diem if there's a patient that they don't want to send out. So, but these buildings do not want to cut into that global benefit.
of course.
So unfortunately, urology is sadly is just not one of the top consulting specialties that they want. Wound is always the biggest. Cardiology, they'll send out if it's a Med A patient too. If it's a Med B patient, they'll have cardiology come in, but uh, podiatry, possibly dental, maybe. But wound is probably the one and only Med A consultant that they actually will come in. And I'm sure that they probably have a lot of contracts with facilities with Med A because they have to treat those wounds. But if someone comes in with a Foley catheter and has a recommendation for urology follow-up from the hospital, they're just going to send them out because they don't wanna have to dip into that fund.
Correct. And as they say, uh, no margin, no mission, or something like that. You have to run a profitable practice, just like these long-term care facilities.
Correct, exactly. So they have to look at their bottom line too. So that's why when I go into a building and explained and orient them to what I do, the fact that it's not going to cost them anything because I'm going to bill Medicare B and commercial
They
insurances.
love you.
Well, that's great.
You're
You can come in
providing a
and see all the
service that,
patients you want.
yeah,
Right.
the patient benefits, you're providing a service, and then you
Correct.
independently bill
Right.
without. So you're billing, it sounds like what you're saying is you're billing outpatient codes, outpatient service codes, and then some CPTs for the bladder irrigation and things like that. Am I mistaken?
So the E&M code, there's actually one for long-term care, initial visit, long-term care, subsequent visit, and also for assisted living, subsequent and initial visits. So those are the codes that I bill under. So it's usually like a 99309, 99310. It depends on how complicated the patient is, but I try to always keep it at a 99309.
And then where are you doing all that documentation of the care that you provided?
What am I doing with it?
Where are you
Is-
doing the documentation? Are you
Oh, where?
writing,
Oh,
do you
where?
have your own
So
chart, or does it stay at the facility, or how does that work?
So they have to have a copy of your note. They have to have a consult note. Typically, again, it depends on the building. I usually like to have access to their EMRs, which is usually either point click care or matrix. So at least that I can see the active information on the patient demographics. I can see their medications they're on, lab work that they've had done. I can see vital signs, et cetera, any radiology exams they've had. So I like to have access to their EMR. And then typically what I do, it depends on the building, but I'm a little bit old school. So I do have a paper consult note. And honestly, it'll depend on how many patients I have to see in a day. So if I'm like super busy and I'm now, mind you, remember, it's just me in the buildings, and some days are crazier than others. There's different floors. It's not like being in private practice where you have a staff that's going to prep a patient and you go in and see them, and that cuts your time. Okay. So it's just me doing all of these things. So sometimes I run out of time. So I will write a paper note and then I'll leave that for them and they scan it into their EMR or I'll scan it into my EMR. We scan things into the EMRs all the time. If I don't have time to actually type into my EMR document in the EMR, but the EMRs interface with the facilities. So you can set it up where when you type a note into the EMR and you click sign, it automatically prints out at the facility. So they have a copy. So do it one way or the other. It depends on how the day is going.
Yeah, it sounds like it's facility dependent, also depending on how sophisticated these facilities are, whether it's still on paper or maybe a hybrid or maybe just using the EMR that they have on site. It
Right.
seems like there are only a couple of major players in the long-term care facility documentation, electronic medical records.
Yeah. So yes, PCC and Matrix are the two big ones, at least that I see out in this area. Some of the companies have maybe their own, so they're not nationally used. They've developed their own. But yeah, PCC and Matrix.
And so whenever you go to these facilities, I assume that they have different types of catheters available. And you also mentioned
Mm.
pessaries and then
Yes.
possibly using E-string and possibly providing some chemotherapeutics or maybe LHRH agonists. Some of these things can be pretty expensive. How would that work?
So pessaries, we always say, well, Martha would say, this is my gift to you. So it's not always reimbursable. However, when push comes to shove at the end of the day, it's what the patient needs and it's what the patient needs. So pessary, depending on who you buy it from and what style it is, maybe around $60, give or take. So unfortunately, sometimes that's just the way it has to be. So yes, I do pessaries. Those are changed every or cleaned and replaced every 3 months. It's reusable, obviously. I don't have to buy them a new one every 3 months. So it's just a one-time gift. S strings. So I write an order for an S string. The facility will send it to their contracting pharmacy, and uh, I'll make sure that it's there before I go. I'll have them order it. So it'll be there when I get there. And as far as any chemotherapeutics, I had one or two patients that were just on maintenance, so I would go in and give that to them only because the patient was, and honestly, the conversation need to be had. Why are we still doing this? The patient was mid 90s. It had been years. But they were still going out, but had some sort of uh, incident and they couldn't go out anymore. So it was just easier. The staff ordered the medications from the pharmacy and I came in and just gave it. It was just a sub-Q injection, so the patient didn't have to go out. But yeah, definitely the conversation had to be had of why are we still doing this.
Sure. Oh wait, so now this is great being able to provide care, but then you have to make a living. And this is not
Hmm.
easy what you're doing by any means, as you said, especially when you're doing everything yourself. Oh, I was going to say, with the documentation, you can consider having somebody either in person to do the scribing for you, or maybe consider a virtual assistant to do the scribing. All right. So that's one couple of ideas. Or you can use artificial intelligence to kind of listen to what you're doing and possibly doing the documentation for you. Maybe. I don't know if that'll work in the type of long term care facility care that you're doing, but that's something to consider. When it comes to billing, you provide these services. You have a couple of long-term care facility codes. You do procedures. How do you then translate that into income for you? I know you have to, I guess, use those two codes and then the procedure codes. And then what happens? How do you record it? Where do you send it to? What is the potential revenue stream like?
Okay. So I am old school. I like to see things on paper. I use a super bill, document on that. It's just check boxes. Takes us half a second. Batch them at the end of the day and just Dropbox them off to I have a billing company. So they do all my billing, and they manage any unpaids. My collection is about 99.9%. So the only time I wouldn't get paid for seeing a patient or not reimbursed would be is if, oh, they ended up being med A and I didn't know it for some reason when I saw them, that type of
So
situation.
you have to have that base knowledge of what type of insurance the patient has at that facility before
Mhm.
you engage in any sort of services. Is that correct?
Correct. So when the facility wants me to see a patient, they send me a face sheet, which
Got
has
it.
all the demographic information that is scanned into our Dropbox, which our billing company has access to. So
Got it.
they can go in and see it. They've got it in their system. So when I just send off a super bill, they can bill for it right there on the spot. They can always go back into Dropbox. So the billing is done every day at the end of the day, which most practices, I would assume that that's what you do.
Sure. How,
Yeah.
is there such a thing as a deductible for long-term care facility?
Yes.
Okay, so
Yes. Yes.
is that where
Yeah.
that 0.
Dreaded January 1st.
Is that where that 0.1% of uncollected goes?
No, because I personally hold back until a deductible is met.
So okay, this
So
is something that is done by that's mentioned in the thriving urology practice before, where at
yeah.
the beginning of the year, you smaller vendors and practices will not bill the services that they provided right away. Instead, they let that deductible hit another practice venture business first,
Mhm.
and then
Mhm.
you submit your claims afterwards after that deductible has already been attributed to another practice
Right,
like a
correct.
long-term care
The
facility
primary
or
care,
a
typically
primary.
the primary care, because they're going to see them once a month, at least every 60 to 90 days per the Medicare guidelines. So typically January actually isn't too bad because it's December's reimbursement. So it's usually February, March, and then once April 1st comes around, the second quarter, it's all back to normal. And all that billing that was held will be submitted, and then it all comes in April or so.
Got it.
Mm.
So it
Mhm.
sounds like there's about a 30-day cycle
No,
of.
so as far there's the outliers, but as far as Medicare goes, you can count on when you're going to receive your monies. You can know what's in the pipeline. So part of my day is actually going in to NGS Connects, which is part of CMS, and seeing that they'll give you drop downs. So seeing the provider's earnings to date, so you can see like what's coming down the pipeline, what checks are going to be cut. When a check is going to be cut, you know that, and it's direct deposited into the business account. So I have EFT, so I can see, oh, okay, so much is going to be paid, or they're going to release so much today. So that means it'll hit the account in 2 days or less. So you can see, and then they'll let you know what you've earned to date. So you'll
Got
know
it.
at the end of the, yeah, it keeps a running total. So you'll know by the end of the year. So, and that's how you watch your numbers. So I do numbers weekly, monthly, quarterly, and yearly.
Yeah, you
It's a
mentioned that in your
numbers
post.
game.
What metrics what KPIs do you look at? Key performance indices do you look at?
Yeah. It's all on based on volume. Also, too, I look at procedures. So, why did I do more CMGs in February than I did in March? Did I have more new patients? Because every time I see a patient, I'm not doing a CMG. Every patient I see, I'm doing a bladder scan. But every patient I see, I'm not doing a CMG. So those are typically for new patients, or if there's some sort of issue that came up and things have changed. So did I have more new patients maybe in February than I did in March? So I look at why that might be. And then you know where you need to work on. Okay, well, we need to work on getting some more referrals in for the next month. I also keep track of how many new patients I'm getting per day, per week, per month. And that total is averaged out every month. And then at the end of the year, I can look at, well, how many new patients did I have total in the year? And then I also compare it year to year. You want to keep these numbers and you want to keep these statistics, because if someday you want to sell your practice, you can't just tell them what a great practice it was and how well they're going to do. You have to have numbers. You have to have numbers. You have to have things inputted, data input, documentation on what those numbers are.
Yeah, I
Mm.
mentioned in the past that you can't improve what you don't measure. And that's why, even as a solo
Correct. Yeah.
practitioner, I look at my
Mhm.
numbers on a regular basis and I freely share that
Mhm.
information in the Thriving Urology Practice Facebook group.
Mhm.
Yeah.
Right.
Well, go ahead.
No, I was just going to say the other thing too is I also get a report from my billing company every month. So they'll break it down for me too. I can ask them to break down anything, but there are certain things that I like to look at every month, and they break it down by building and they break it down by insurance company, so I know who's paying what and I know which buildings where I'm making the money. So maybe those buildings I want to go to more often because maybe they just have more patients. So like the building I have down in New Haven, they're a big building, so I need to go there,
And it's a
once
lot
or
more
twice
efficient
a
for
month
you.
anyways, but
Yeah, and
mhm,
it's a lot more
yes.
efficient for you.
Yeah.
You go to one
Yep.
place and you can
Right.
see 20 to 25 patients instead of going to two different
Correct.
places and then
Right.
seeing the same number of
Exactly.
patients. It's all about
Right.
efficiency.
Yeah, exactly. Because if I have a small building, there's only 10 patients. I know that, I can't, I can see more than 10 patients in a day. So I'll have another building that's close by or something. And demographically, I group them. So I'll go to both of them in the same day. And, too, sometimes you get to a building and, three people have either been discharged or passed away. So
Yeah,
you
that's true.
want to,
Attrition.
try to schedule or plan for seeing more patients in a day. So then at least I'll hit the number that I want, between 15 and 20 anyway. So if I book 20, 25, then I know, well, either I'm going to have a really busy day and that'll be great, or at least I'm going to walk out of there knowing that I hit my numbers for the day.
So it's interesting. It's, I guess, similar to private practice outpatient care in that it's,
Mhm,
like you said, the very outset, it's a numbers game, right? So
mhm,
it's because you know the major payer is going to be Medicare, and you are looking at your metrics. You're looking at what your production is, potential production, and then what your churn or attrition, patient attrition may be, and possibly how do you improve your performance? How do you increase that number? And I think it's pretty easy to ascertain, assuming that you work Monday through Friday, you're seeing 20 to 25 patients, and then there are only two long-term care facility care codes that you will use, and then CMG, catheterization, and things like that. Those are the codes that
mhm,
you could build,
mhm.
procedure codes. I guess for anyone who's trying to create a pro forma, they can pretty easily come up with the numbers. And I'm not going to ask you for your numbers, but feel free to share if you wish. But you're basically seeing patients from 8 to around 3 o'clock in the afternoon. Is that right?
Correct.
Okay. So that's
Right. Yeah, I try to break it. Typically, I'll see 10 in the morning, 10 in the afternoon,
got it.
and then give or take depending on, what's going on with the census. In the morning because you want to see them in the morning before they get going. So typically, if I get to a building around 8, some of them or most of them may still be in bed. Unless I need them to be in bed for some reason, I'll call ahead and say, make sure Mr. Smith stays in bed, or, Mrs. Smith stays in bed. I need to change your estering, because those are other things to think about where, maybe someone's Hoyered, they just got them up and, oh, they don't want to have to put them back. And so that could take a little bit of time on both ends. So typically 10 patients in the morning, and it takes me maybe hour and a half at most, depending on if there's something, going on that delays me. And then that's when I have an hour or two to kind of get organized and do my documentation, etc. And then if I'm going to stay in the building, then I'll see 10 more in the afternoon. So then I can have something quick to eat, and the patients can have their lunch, because you try to also abide by their schedule. It is their home. So I can't just go in there and say, well, you're not going to have lunch right now because I need to, straight cath you. They're going to tell you no. So you have to kind of work with their schedule. So they have their lunch, and then I'll go and catch them all between 1 and 2 or so, before they go to bingo and the hairdresser or go out or something like that. So and then I'll do my documentation at the end there, or sometimes I take it home and I'll just do it later at night, something like that.
Yeah, so you are doing taking charting home, which is one of the things
I
that I
try not to, but
yeah,
yeah,
it was one of the things that I try not to do. Well, as we
right.
draw this interview to a conclusion, what would you share with the listening audience who may be interested in delving into this field of urology?
Urology or in
Long-term
long-term
care.
care?
Long-term care,
Well,
urology.
y- yeah. So you can reach out to me. I'm happy to answer any questions, or talk to anyone. I think we need more providers. You can definitely do it. So don't let the fear of doing it or anxiety of, oh, how does that work? You can do it. You've got to start somewhere. And the patients need you. They're a vulnerable population. Like you said, 10,000 people a day sign up for Medicare. Okay. So there's a large population that is not being seen or treated. So they all need you. One of the things that we say is that the building will ask us, well, how do you know who to see? And I always say, they all need to be seen. So there's plenty of business out there. There's plenty, even the women. I see men and women. Martha had just seen women, but I see both. But every woman in the building is going to be atrophic. They're all going to need estrogen, at least, even if they're not incontinent. So they all need a visit. So there's plenty of business. You can do it. You just need to connect with the right people, and follow the right process to be able to get set up. But it's not hard. And then once you get going, you'll be so happy. You'll be so happy. You'll be in control of your schedule, your work. It's fantastic.
Well, thank you so much for this amazing interview on a field of urology, the provision of urology that most of us have no idea. And your insights are just truly, truly golden. So thank you so much, Melissa.
Oh, thank you for having me. I enjoyed it.
All right, so stay on as we do the
Okay.
outro. Hey, You guys have stayed until the very end. I really, really appreciate it. If you have any questions or comments, feel free to leave them below, and I will definitely try to get these questions to Melissa. Thank you so much for the privilege of your time. Please take care of yourself and each other. Bye-bye.